You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. I'm your Breathe Easy host, Patty Tripathi. Thank you for watching and listening in. This podcast is about Supplemental Oxygen Reform Act. It affects some 1.5 million people living with chronic lung and heart diseases. Joining me today are Jager Spratt and Susan Jacobs. Why don't you kindly introduce yourselves and your involvement? Jager.
Hi, everyone. I'm really glad to be on the podcast. Yeah, I'm Jager Spratt. I'm the Advocacy and Treatment Access Program Manager with the Pulmonary Hypertension Association. So I'll be bringing in some of the policy perspective on this podcast.
And Susan, you are in charge of 30 patient groups that have signed on and with the ATS, correct?
So I am a pulmonary nurse specialist, and my current position is at Stanford as a research nurse manager, but I've been involved in patients using oxygen for many years. And I chair the ATS Oxygen Special Interest Group, which we started in 2015. And this is a multidisciplinary group that represents, as you mentioned, multiple organizations, advocacy and professional organizations, as well as we have patients, respiratory therapists, nurses, and physicians join our group and have worked on oxygen issues for the last 10 years.
Thank you.
It's a really wonderful group, so definitely glad that PHA is able to be counted among them.
Yes. Thank you. And Jager, this is not the first time. This is the second iteration of this SOAR Act. Tell me, lay of the land where it is right now. It's a bipartisan bill.
Yeah, that's right. So it was initially introduced, I want to say in November of 2023. So it only had about a year run in the previous congressional session. It's now been reintroduced this past August. So it is in both the House and the Senate, and it is, like you said, bipartisan. So because there's a Republican majority, there's a Republican original sponsor, and then several Democratic original co-sponsors that have signed on for both Senate and House versions.
And Susan, 30 patient groups, and I have all of their logos here, have signed on. What is ATS's involvement, again, deeper into the question that you had answered earlier?
Well, I think it goes back to the original recognition of oxygen as a huge issue for our patients. And that was in around 2015 in the American Thoracic Society. We call it a nursing assembly, where we saw a dramatic increase in patient complaints, patient calls to the nurses. We all dealing with this every day. They couldn't get equipment. They couldn't leave the house. They had problems getting callbacks. So at that point, there was no data to present. So we actually did a survey and published that in the American Thoracic Society Journal of almost 2,000 patients across the U.S. And we documented more than half the patients reporting problems. And the top 4 or 5 included equipment that wasn't working, broken equipment. They couldn't travel. They couldn't get what they would consider portable equipment that they could physically manage to get out of the house, and couldn't get enough high flow equipment to give them adequate oxygen. So that really, ATS played a key role in getting that initial data out. We followed that with a multidisciplinary workshop report where we met with, again, a multidisciplinary group for a day and developed very formal recommendations for various stakeholder groups and published that as well. So the American Thoracic Society has provided what I would call a home for oxygen. We identify research gaps. Clinical practice guidelines were published recommending and looking at the evidence. So oxygen use crosses multiple patient populations, multiple diseases, inpatients, outpatients, pediatric, adult, cardiac, and many different pulmonary diseases. So the American Thoracic Society really provided us a home for advocacy, research, clinical expertise, and it's been very instrumental in bringing this together and working with other professional organizations.
Tell me about liquid oxygen. What's happened to that?
So I think it's important to know there's 3 forms of oxygen that we prescribe to patients. So one is compressed gas, which is what most of us see out and about, maybe in the hospital and even out. The green tanks, different sizes, compressed gas in a hard tank. You pull it in a trolley or put it on your back. The second is what we call concentrated oxygen, which draws oxygen out of the ambient air, concentrates it, and you can use a portable oxygen concentrator, which you see advertised as a purse-size device, or a larger stationary one for the home. That device pulls oxygen out of the air, concentrates it, and it runs on battery. You can plug it in, but it runs on battery. The third type is liquid. So liquid oxygen is oxygen that has actually been super cooled down to a liquid form, but when it comes out in the air, it turns into a gas. The difference with liquid is you can compress a large amount of oxygen into a smaller space. So for equal volume containers, one containing liquid oxygen will last that patient much longer and can run at higher continuous flow. That means the flow is continuous. And that patient refills it at a home reservoir. They have a large tank at home. And when they go out, they just click on their portable device and they can turn it on and then they leave the house. So the main difference is liquid provides more oxygen in a portable space. So the patient can be out of the house longer. And the most important thing is it can run at higher flow rates. And that, for a subgroup of our patients nationally, internationally even, they have high flow needs. So if a patient has low flow needs, that small purse-sized portable concentrator, which goes to about 2 liters a minute, no more, that may be fine for them. But we have another population of patients that are active, out of the house, working, caring for families, traveling, et cetera, but need high flow, meaning 4, 5, 6, 10, 15, even 20 liters a minute. That would enable that population as well to get out of the house.
One other thing to highlight that I hadn't realized about liquid oxygen until a little while working on this issue, but it's also a form that doesn't require electricity to run. Is that right, Susan?
Right.
So that actually makes it an extremely valuable form of supplemental oxygen to use during emergencies or like natural disasters. So if there's a power outage, people with liquid oxygen can keep using their oxygen for, potentially a couple of days, versus if you have, a pump that needs to be hooked up to the wall, that's immediately going to be useless once you lose power. So I think especially as, storms get more severe and that becomes a more frequent issue, I think that's another piece that makes it even more important to get people back to being able to access liquid oxygen.
I have my own personal frustration and sadness. My mom actually was on low flow. I don't think she was ever over 4. And that's when she was running around. She was very active and didn't use much at home. But she was a very tiny person, not even 5'11". The oxygen tank was so huge. And it really made it very difficult for her. It was like carrying a, scuba gear with her until the portable oxygen came along. How does this legislation affect all that?
Well, liquid oxygen is more costly. In terms of, it requires we call them DME, the Durable Medical Equipment Company, to come out on a weekly basis and refill that big mother reservoir. So that's a cost to the DME. And it also requires specialized trucks and training because of the management of liquid oxygen. And over the last 10 years, really since this onset of competitive bidding, which was a change in the way durable medical equipment companies were reimbursed by Medicare, which lowered their reimbursement. Because of the cost of liquid, it was the first service that was really eliminated in order for them to maintain, financial health of the DME. So the cost of paying a driver once a week to go out and manage these and the equipment their reimbursement cuts from Medicare, it didn't allow that. So that was the first thing that we lost. So we saw an 80% drop in the number of patients using liquid oxygen from about 2010 to 2016 or 17. So it's very cost effective for a DME to have like a home fill unit, patients fill their own compressed gas, and that DME doesn't have to go to that home every week. So it's a cost savings. They also lost the ability to have a respiratory therapist on their staff. We just saw a lot. That's why we saw this huge increase in patient dissatisfaction after that. They would call, no one answering the phone. Deliveries were either delayed or, not enough deliveries. So liquid oxygen really took the biggest hit in terms of that financial hit. And our patients needing high flow, they were the most dramatically impacted. So they lost access to liquid.
Did you miss the ATS 2025 International Conference in San Francisco? We've got you covered. With the ATS Conference Highlights Package, you can access inspiring presentations as well as valuable clinical insights from pulmonary, critical care, and sleep sessions. Members get a discount, so become an ATS member or renew your membership to take advantage of these savings. Go to conference.thoracic.org today.
Just to give an example, under Medicare Part B, a person may have various out-of-pocket costs for oxygen therapy. In 2025, there's an annual deductible of $257. After a person meets that, there are many layers of expenses. Must pay 20% coinsurance, the rental costs, the portable oxygen concentration. And then after making those monthly payments, for 36 months, these payments cover maintenance, accessories, and repairs. The lifetime of this, all this equipment is 5 years. I mean, what happens then?
So they have so they would start over again, basically. So the first, like you mentioned, and Jager, you can add into this, but the first 3 years, they're under contract with Medicare. They pay 20% of their deductible or their fees, but the DME manages that equipment. But then that last 2 years, they stop that payment, but they still have the equipment. And supposedly the DME company is still servicing and taking care of it, which often doesn't happen, but that's the agreement. And at the end of that 5-year cycle, they would start over again. One of the big issues with that setup, if a patient signs on with a DME and they're in it 6 months, let's say, and their oxygen needs go up and now they need more E-tanks or higher flow concentrator, which doesn't really exist, or liquid, they can't change DMEs at that point because that DME is already had that patient for up to a year and they would lose the rest of that contract. So it's very hard for patients to change their company once they start. That's another negative. And I don't know, Jager, if you have other comments there.
Yeah, I mean, so from what I've heard from patients who've contacted PHA, it just makes it super difficult, like you said, to change those contracts. And so basically the DMEs are getting reimbursed at not a terribly high rate, but they are getting reimbursed for those first 3 years. And then those last 2 years, because it's still a 5-year contract, those last 2 years, the companies are basically supplying it for free. So you can imagine that's going to make that customer service just really tank. And you can see that in the Google reviews for national oxygen supplier companies. They're really poorly rated. So it just kind of has a cascading effect that negatively affects patients and leads to equipment not getting checked up on, not getting maintained well. As far as the lifespan of the equipment itself, I don't know that. I'm not familiar with necessarily a requirement to replace the equipment every 5 years, but I think it's more that contract then is kind of when people potentially have the chance to change, especially if their oxygen needs have changed, or just to do anything else. But it's a struggle to make it all the way through to the end of that 5 years because of the lack of adequate reimbursement.
So where are we now? There are how many Republicans congressmen that are supporting this, and is it?
Yeah. So on the Senate side right now, we don't have any additional co-sponsors as of yet. So there's the one Republican who has introduced it, which is Senator Bill Cassidy from Louisiana. And then the co-sponsors are Senator Mark Warner from Virginia and Senator Amy Klobuchar from, I believe, Wisconsin. And then on the House side, I believe we are now up to 18 co-sponsors last I checked. So that one is trending a little bit more Democratic right now. I mean, I will say with other things going on in Congress, the Republicans have their hands quite full. So, perhaps over the summer we can kind of get that balance back in order. But it is still certainly a bipartisan issue and, shouldn't necessarily be divided down party lines at all.
So what can people do if you are affected or a loved one, physician, medical care provider, neighbor? You're imploring that they contact their congressmen or senators to.
Yeah, absolutely. I think really anybody, literally anybody who has ever had experience with supplemental oxygen, whether that's your own experience, whether that's a loved one's past experience, and especially if you are a medical provider who has patients who need some kind of supplemental oxygen. All of these stories are very, very valuable to bring to your members of Congress. The most impactful way to get policy change to happen is for constituents of an office to talk to their elected official. We as patient advocate organizations certainly can go up to Capitol Hill and do often to advocate for it, but having a constituent of that office come to that legislator or more realistically their staff and share those personal stories, that's what gets policy change made. So anyone who has those experiences, if you're unfamiliar with the process of advocacy, it truly is not as hard as it seems, although it can seem intimidating. But just starting out by reaching out to an association that you're already connected with and asking about their advocacy work is a great way to get started. PHA has an advocacy action center on our website that's very accessible, and I'm happy to have that link shared in the show notes. And there's, as we've talked about, over 30 other organizations, and many of those organizations have really robust advocacy programs as well. So there's just truly a plethora of resources out there to help anybody who's interested in sharing their story to make sure that they get heard.
And very compelling are the stories. And you will be bringing patient stories coming up in the second part of this podcast, correct?
Absolutely, yeah. So this is a two-parter. So I'll be coming back with some really wonderful people who both are patients and require high-flow oxygen and are very impressive advocates themselves. So I hope listeners will be able to enjoy their stories and feel a little bit inspired to take on this issue as well. It's definitely a big group effort.
Susan, is there anything else you'd like to add that I didn't ask you?
Well, it's been such a long time issue. We really are anxious to improve the quality of services for our patients. It's not just about liquid. That is a huge piece because our patients end up isolated, unable to leave the house. Many of these high flow patients are preparing for a lung transplant and they're required to undergo pulmonary rehabilitation, which is exercise. Of course, we want all of our patients exercising. We have patients now that leave the house under oxygenated, so they're hypoxemic. And that can be very serious with medical complications for patients, especially who need oxygen at rest, can create what we call right heart failure, pulmonary hypertension. So access to high flow to keep those patients out of the house, active, able to, travel, go to religious services. We have populations with young women that are caring for small children and trying to get, or others caring for older family members. And then the quality of care, losing a respiratory therapist in these DMEs was a significant loss to us. We would call, we need to ask questions about flow rates and equipment combinations. And it's difficult now because there's really not a professional there. The other advantage was that we could have our patients tested on the equipment they were going to be provided with. And we want to know that that equipment keeps them oxygenated over a certain amount. And we don't know that now. We test them in our clinic on our equipment, but we don't know what they're going to actually be given. So loss of the respiratory therapist was another big issue. I think the education piece is also huge. Patients, our survey showed that 70% of patients are trained by the truck driver dropping it off. And that's if they're lucky, they're there. So there's lack of education. And that means that patients are less likely to adhere to what we're prescribing for them. So patients won't use the equipment if they don't understand that it's broken. They don't understand maybe there's another option.
And that's you're asking for respiratory.
Yes, that's for that educational component. Or this SOAR Act also includes a Bill of Rights. And one of those Bill of Rights is that patient will be trained and the family how to use the equipment, how to maintain the equipment. That should be a standard of care. And that doesn't happen, and safety,
It is a safety concern. Yeah, One of the patients that I'll be talking with on the upcoming episode has had that exact experience of be really, really benefiting from the respiratory therapist back when she had first started on oxygen. And she credits that respiratory therapist with, making sure that she actually adheres to the prescription because, she was like a young 30-something working mom and understandably felt really self-conscious about wearing oxygen out in public. So, if someone just gets that equipment dropped off at their home with no great instructions on how to use it, certainly eventually when they meet with their doctor, the doctor can talk to them about the importance of adhering to it. But having that process of being in the home, getting walked through how to use the equipment and the why it's important is something that patients really do need and are currently missing out on. But that is one component of the SOAR Act that would actually make sure that those services are reimbursed. And so that would make it, financially feasible for DMEs to be employing respiratory therapists again.
Okay. And what is your call to action?
Yeah. So support the SOAR Act, get in touch with your representatives. They're, like I mentioned, the PHA's Advocacy Action Center, we have a pre-written message template. So it's super easy, just a couple clicks, just a few minutes, and you can send a letter to your members of Congress. We do have a little box in there for you to customize and include your own experiences. And then, for anyone who has the time and the willingness to do more, you can make calls to your office. We have also a call script there within the Action Center as well. And then even reaching out to either PHA or other patient advocacy organizations and setting up meetings with your legislators in particular, that can go a really, really long way if you can make that personal connection with members of your legislator staff. And those are super easy to do too. You can do them on Zoom. You can do them from home. And we're more than happy to set you up with all the talking points. You don't need to know the details of the policy. Just being there and sharing your personal experience is going to be the most powerful advocacy tool in your tool belt.
And obviously, you're hoping that it passes by 2026.
Yes, that is absolutely the goal. Yes, we ideally would love to not have to reintroduce this bill again in 2027.
And I would like to put out that same call to action with an emphasis on our medical professional world. We need the data. It's been very hard to get that data, and especially around patients. For example, now we have patients who are unable to leave the hospital because they do not have high flow oxygen at home. And this we are trying to get data. And we know that this happens in especially transplant centers where we have some responses already that 3 to 4 patients at any one time are in a hospital for up to 2 to 4 weeks extra, only because they can't get adequate high flow oxygen to be discharged. They are medically stable, but they can't get enough oxygen, high flow, to be discharged home. So we really need the data on those kinds of things. Any, medical admissions, ER admissions around issues around oxygen, to really document the impact of this problem across lots of populations. So I would ask, and also writing editorials, op-eds. So we call on medical professionals to really help us get this passed and provide that information.
In the process. Well, I hope to have you back when we are saying that the SOAR Act, as you want it, passed. And for now, thank you so much, Jager and Susan. It's lovely to have you.
Thanks you.
Thanks for having me on. Appreciate it.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.